Hello, my name is Mark Lee. I am a clinical microbiology fellow at the University of California, Los Angeles. Welcome to this Pearl of Laboratory Medicine on antimicrobial susceptibility testing. Bacterial pathogens like Staphylococcus aureus can cause skin and wound infections, sepsis, and pneumonia, among others. While our body's own immune system can typically ward off and maintain control of invading bacteria under normal conditions, there are instances where the balance is tipped in favor of the pathogen, resulting in an infection. This is where anti-infective drugs like penicillin or vancomycin can come into the picture. These are antimicrobial agents against bacteria that can inhibit growth and help the body clear infections. There are several classes of antimicrobial agents against bacteria. Some agents, like the cell wall targeting beta-lactams, are bactericidal, meaning these agents kill the organisms outright. Others, like the protein synthesis targeting aminoglycosides, are bacteriostatic, meaning these agents inhibit growth and proliferation, but does not necessarily kill the organism. While some cases of bactericidal agents are more effective than bacteriostatic ones, in most instances, either type of agent is sufficient to give the immune system the boost that it needs. The identity of the invading bacteria is important since some bacteria are predictably susceptible to certain antimicrobials. For example, Streptococcus pyogenes, also known as group A strep, is susceptible to penicillin and has no known resistance mechanism against this drug. Thus, patients with a group A strep infection can be treated with penicillin without the need for antimicrobial susceptibility testing. Then there are bacteria that are predictably resistant to certain antimicrobial agents. This is due to their intrinsic resistance to those particular drugs. An example is Pseudomonas aeruginosa and penicillin. Pseudomonas aeruginosa is intrinsically resistant to penicillin due to the presence of chromosomal beta-lactamases. Therefore, other antimicrobial agents are used to treat patients with this infection. The challenge is when susceptibility is not predictable due to acquired resistance. A good example is Staphylococcus aureus, which used to be predictably susceptible to penicillin and its derivative drugs like methicillin. Patients with Staphylococcus aureus infection used to be treated with these drugs. However, emergence of acquired resistance, like penicillin hydrolysing enzymes and penicillin-binding proteins, has led to the rise in methicillin-resistant Staphylococcus aureus, commonly known as MRSA. Patients with MRSA infections are usually treated with non-penicillin drugs like vancomycin or daptomycin. However, many Staphylococcus aureus isolates do not possess one of these acquired resistance mechanisms and are still susceptible to penicillin. These are known as methicillin-susceptible Staphylococcus aureus, or MSSA. Patients with MSSA infections can be treated with penicillin, like oxacillin or nafcillin. Beta-lactam drugs are preferred over vancomycin due to better patient outcome in critically ill patients. Thus, classifying a Staphylococcus aureus isolate as MRSA or MSSA is important in proper management of patients. In order to assess whether an isolate has an acquired resistance to a particular antimicrobial agent, an in vitro antimicrobial susceptibility test is performed. This typically involves exposing the isolate to a panel of antimicrobial agents, usually antimicrobials in the hospital formulary, and determining at which drug concentration growth is inhibited for each of the drugs tested. The results of the susceptibility test will provide guidance to clinicians on which drugs to use, which to avoid, and which to alter the normal dosing regimen for successful patient outcome. This is a routine service provided by the microbiology laboratories. There are various methods to test antimicrobial susceptibility. These include phenotypic tests like broth microdilution, diffusion, NE test, as well as tests to detect the presence of resistant genes or enzymes. For this presentation, the two commonly used tests, the broth microdilution and diffusion, will be discussed in detail. The antimicrobial susceptibility testing begins with preparation of the inoculum. The first step is to select 2 to 3 isolated colonies with a sterile cotton swab, usually from an overnight culture grown on non-selected media. Second, suspend the colonies in saline or sterile water. Third, adjust the suspension to obtain the desirable turbidity, usually 0.5 McFarland standard, which can be read by a turbidity meter. 0.5 McFarland is roughly 1 to 2 times 10 to the 8 CFU per ml. The next step is inoculation. This can be accomplished using various inoculation apparatus. A manual disposable tray inoculator is shown on the slide. The 0.5 McFarland suspension is diluted further and poured into the inoculation tray. The inoculator is dipped into the inoculation tray, which collects about 10 microliters of the suspension per needle, labeled A on the slide. This is then inoculated into a 96-well MIC plate containing the antimicrobial agent and broth medium. The final concentration of organism in the well, in each well, is about 4 to 5 times 10 to the 5 CFU per ml. Some difficult-to-grow bacteria may require additional supplementation in the broth. The inoculation tray is then incubated, typically at 35 degrees in ambient air for most organisms for about 18 to 24 hours, but some may require longer incubation and/or carbon dioxide. At the end of the incubation period, the MIC plate is placed on top of the viewing device for manual read. Growth in each of the well is visually checked. Automated reading devices are commercially available. The first well with growth inhibition for each antimicrobial agent tested is recorded as indicated by the red arrow for linezolid. In this example, Enterococcus faecium was tested with linezolid MIC of 2 micrograms per ml and vancomycin MIC of greater than 32 micrograms per ml. Another common method of antimicrobial susceptibility testing is disc diffusion. As with the broth microdilution test, a 0.5 McFarland suspension is made. A sterile cotton swab is submerged in suspension, excess liquid drained, and streaked on a Mueller-Hinton agar plate to make a lawn of bacteria, as shown in step 1. After letting the plate dry for a few minutes, filter discs impregnated with the antimicrobial agents of interest are placed on the plate, as shown in step 2. 4 sets of dispensers can be used. Once all the discs have been placed, the plate is incubated under the appropriate growth conditions. As with the broth microdilution method, some difficult-to-grow bacteria can require additional supplementation. The inoculated plate is incubated at 35 degrees in ambient air for most organisms for up to about 16 to 18 hours, but some may require longer incubation and/or carbon dioxide. In contrast to broth microdilution, where a range of serial dilution of antimicrobial agents is tested, in this diffusion test, a single impregnated disc per agent is placed on the plate. The principle behind this diffusion is, as the name would suggest, the gradual diffusion of antimicrobials from disc out throughout the agar, creating a gradient as shown in panel A and B. The closer to the disc, as illustrated with black arrows, the higher the concentration of the antimicrobial, and further out from the disc, as illustrated with the white arrows, the lower the concentration. From the gradient created by the diffusion, a zone of inhibition forms depending on the susceptibility of the organisms, as shown in panel A. The zone of inhibition is measured in millimeters. Some resistant strains can actually grow up to the disc, as shown in panel B. In these cases, the zone is typically reported as the diameter of the disc, usually 6 mm, but some laboratories may report as 0. To measure the zone size, the plate is held against a dark background, and the zone margins are measured by a ruler to the nearest whole millimeter. In this example, Pseudomonas aeruginosa was tested with tobramycin, zone diameter of 25 millimeters, as shown in A, and ceftazidime zone diameter of 32 millimeters, as shown in B. The MIC or zone diameter itself is not particularly informative without some interpretation. This is where breakpoints, also referred to as interpretive criteria, come into play. Breakpoints basically categorize an isolate as susceptible, intermediate, or resistant to a particular antimicrobial agent based on the MIC value or disc zone diameter. In the broth microdilution example, the Enterococcus isolate with a vancomycin MIC of greater than 32 will be categorized as resistant and thus will be a vancomycin-resistant Enterococcus, also known as VRE. The clinician receiving this result will know not to treat this patient with vancomycin and instead may treat with linezolid since it is tested susceptible. Various organizations establish breakpoints for organisms commonly encountered in clinical settings. In the U.S., breakpoints are established by the Clinical Laboratory Science Institute, or CLSI, and by the U.S. FDA, while UCAS breakpoints are followed in Europe. Other routine test methods include the use of automated system, as shown in Panel A, and e-test strips, as shown in Panel B. Automated antimicrobial susceptibility test systems are commonly used in microbiology laboratories due to their ease, short turnaround time, and high volume capacity. Usually, a suspension of the isolate is inoculated into a card or cartridge containing antimicrobial agents in a couple of concentrations, placed inside the automated platform, and incubated. Automated systems can provide results within hours by measuring subtle changes in the growth by turbidity, fluorescence, or colorimetric reactions. Depending on the platform, either MIC values or breakpoints categories are reported by the automated system. E-test is similar in concept as disc diffusion, where the impregnated drug on the e-test strip diffuses into the agar, creating a zone of inhibition. Unlike disc diffusion, e-test measures MIC and not zone diameter. In Panel B, this organism has an MIC of 0.5 micrograms per ml of this particular agent. There are three categories of breakpoints as defined by the CLSI. A susceptible isolate is inhibited by the usually achievable drug concentrations when the normal dosage is used. Treatment success is likely. An intermediate or susceptible dose-dependent isolate has an MIC approaching the upper limits attainable in the blood and implies clinical efficacy in body sites where the drugs are physiologically concentrated or when a higher dosage can be used. It is also a buffer zone between the susceptible and resistant categories. A resistant isolate is not inhibited by the usually achievable drug concentrations with normal dosage schedule and or fall in the MIC range where specific microbial resistance mechanisms are likely. Treatment failure is therefore likely. Many factors are taken into consideration when establishing breakpoints. It is a very involved, complicated, and highly technical process. For the purposes of this presentation, we will briefly go over the major points. MIC breakpoints for broth microdilution are established by considering three different cutoff values: the wild-type cutoff, PK/PD cutoff, and clinical cutoff. To determine the wild-type cutoff, a wide range of drug concentration is tested on each isolate. The MIC results are then tabulated as a histogram as shown on the slide for Klebsiella pneumoniae and the hypothetical drug X. The distribution is visually analyzed or run through a mathematical algorithm. This approach differentiates isolates with wild-type MIC from isolates with elevated MIC, potentially due to acquired resistance. To establish the PK/PD cutoff, a variety of studies are conducted to investigate the pharmacokinetics, defined as how the drug is metabolized by the body, and the pharmacodynamics, defined as the relationship between the drug concentration and bacterial killing. The goal of PK/PD study is to determine if drug exposure time, peak drug levels, or a combination of time and concentration is the best parameter in establishing dosing regimen. To establish a clinical cutoff, prospective clinical trials are conducted, especially for regulatory approval purposes. Based on clinical outcomes and antimicrobial susceptibility results of isolates from patients, MIC ranges where most patients respond is assigned to susceptible category. MIC ranges where some patients respond is assigned as the intermediate category, and MIC ranges where most patients fail therapy is assigned as the resistant category. Breakpoints can be revised and updated with shifts in wild-type cutoff, new data on PK/PD, and changes in clinical outcome. In fact, organizations establishing breakpoints, like the CLSI and UCAS, constantly review data and hold discussions to ascertain whether changes to an existing breakpoints are warranted and undertake studies in reassessing breakpoints. Establishing zone diameter breakpoints for this diffusion usually requires knowledge of the MIC breakpoints established for broth microdilution. An isolate is tested with both the broth microdilution and this diffusion methods, and the resulting MIC and zone diameter are plotted in a scattergram as shown on the slide for hypothetical drug X. The zone diameter breakpoints are set to ensure maximum agreement with MIC breakpoints and minimize discrepancies or errors. In essence, you do not want to categorize an isolate as susceptible by this diffusion when it is resistant by broth microdilution, and vice versa. This is shown with the two red arrows. We're establishing the zone diameter breakpoints at less than or equal to 11 for resistance, 12 to 13 for intermediate, and greater than or equal to 14 for susceptible for the hypothetical drug X, aligns the isolate with the MIC breakpoints with the least number of discrepancies. Antimicrobial susceptibility testing plays a pivotal role in patient care by categorizing isolate as susceptible, intermediate, or resistant, which can guide clinicians on appropriate therapy. MIC breakpoints are established by taking microbiological, PK/PD, and clinical outcome data into consideration. Breakpoints can be revised and updated as clinical outcome and susceptibility patterns change over time. Establishing zone diameter breakpoints for this diffusion usually requires knowledge of the MIC breakpoints. Thank you for joining me on this Pro of Laboratory Medicine on antimicrobial susceptibility testing.